Well, we're fortunate on this mid-morning to have some more of the Explore presentations. We've got with us Sofia Isabel Perazzo from the Children's National and Rakesh Rao from St. Louis Children's Hospital. And you both have some very interesting projects that you're presenting. Sophia, you're presenting this CAKUT calculator, a clinical risk prediction tool for in-hospital mortality. Wow, is CAKUT getting a lot more attention these days?
Yeah.
And then Rakesh, gestational age specific mortality in the era of therapeutic hypothermia. When does the cooling benefit begin? Wow, what a hot topic this year. We are sure. Well, Sophia, why don't you start and tell us a little bit about this calculator? We love calculators.
Yes, I think that will something. Yes, I think it's something that as we have access to more and more data, is allowing us to do these risk calculators. So, in this case, the Kidney Focus Group wanted to leverage all the data on CHNC and see how can we better discuss the possibilities and the risk that these babies have over time. And so we started just looking at the data and how we can work towards the risk calculator. And, it was a really long process. It was a very interesting, and we always wanted to give it a lot of clinical significance and not just to crunching numbers. So I think that we end up having a really nice calculators that hopefully everyone can interact with, in a very simple way.
And let me back up a little bit. I jumped ahead. First,
Should we
a
define?
little bit about CAKUT. So anybody who's listening who doesn't recognize
Yep.
that that's congenital anomalies of the kidney and the urinary tract.
Yeah.
How does that affect our NICU population?
So it's one of, depending on the prevalence on the publications that you read, the prevalence is going to be between 1.6 to 17.7 cases per 1,000 live births. So it's very large. It's a very heterogeneous a group of diagnoses. So the risk that these babies have, it's going to be also very difficult to calculate. And additionally, it's a very big this is a very big group of patients that will have kidney insufficiency during URG. So it's a really important population that we need to take care of.
Especially because on one end of the spectrum, the mortality can be pretty high.
Exactly. Yes. Yes. There's some we were able to look at the diagnosis that we have these heterogeneous groups, and we were able to look at some specific diagnoses will have a higher risk for in-hospital mortality, regardless of other comorbidities. So that is something also that I think it can help us work and talk with the families of these babies.
Love that. So you had 13,233 babies from 46 hospitals.
What a sample size.
A huge sample size. Tell us what some of those most common diagnoses were.
So usually the hydronephrosis were the ones that were most commonly seen, and I think that this is something that you also see in your clinical practice.
Sure.
Not necessarily that they will have more relation to the in-hospital mortality, but those were the most common ones. When we start doing the analysis and starting to look at the variables that we wanted to see whether which ones will be the most that we need to pay attention to. Some of the diagnoses that were most importantly were the multicystic polycystic kidney disease, of course, renal agenesis, the horseshoe kidney, and prune belly were among the ones that in the univariable analysis had the highest odds ratios of mortality. And then where there are other factors that also, of course, were very important, like gestational age, the relationship with birth weight, as we know, and how well the baby did during birth, delivery room resuscitation, having a central line, and of course, pulmonary hypoplasia was, a main factor that was important for in-hospital mortality.
Wow.
So yeah.
I appreciated how in your work you really started to create these categories of factors. So as we think about like what are the risk factors, it's it's hard to think of them as a laundry list, but you had the maternal factor, the socioeconomic factors, the perinatal delivery factors, and then the neonatal factors that we're also hyper-focused on in our NICU, right?
Yeah. Thank you for noticing. Yeah, I wanted to, when I presented this work, I wanted to kind of walk everyone through on how we approach building this calculator. And if so, you can, if you can follow the process, maybe everything makes more sense. And then so how we look at what is important and what we need to take into account to building the risk calculator. And so we start looking for all the different factors. And of course, after we doing more and more analysis, we started to looking at which are the most relevant, of course. Reaching out to the pulmonary hyperplasia, this specific kidney diagnosis, and of course, gestational age at birth. One thing that it was very interesting for us was that having vesicoretral reflux was kind of protective.
That is interesting.
It's very interesting. So if you look at the list of when we did the univariable analysis, the ones that had the highest high risk of mortality, odds ratios of mortality, was the abscess of the urinary tract. And that is kind of relates to the fact that having vesicoretral reflux is actually protected. It means we believe that is because we have a urinary tract. But so it's kind of speaking of a malformation that it's not such severe.
So not necessarily the reflux being protective, but the reflux is proxying less severe presentation.
Yes, exactly.
Very interesting.
But it was important enough to put it in the risk calculator.
Right.
So can we use this calculator?
Yeah, hopefully be able to build it and put it in the CHNC website next to the BPD and the CTH calculator. We're just working on the last steps, but all the analysis have been done, and hopefully you will be able to go into the website and interact with it.
And we have lots of trainees and fellows and early career listeners. And so how would you recommend that someone going in to do a prenatal consult or even a postnatal conversation incorporate this calculator in those conversations?
Yeah. So what I would recommend is, I mean, if you have your patient's characteristics, because all these characteristics, you just go to the calculator and you calculate the risk. It's going to have a low, moderate, or high risk, depending on the number of points that the last score, the score that the diagnosis the baby has. And that I think it will give us some tools to be able to discuss based on what we know in the population with these caregivers, the risk of their baby, right?
Yeah, so valuable. And we know that's exactly what parents are looking for. And it's interesting because I think we can give them some information prenatally, and then identifying some of those other risk factors along the admission, I think will give us more prognostic success.
And tell them what we are looking for,
Right.
why we're looking at those things, and help them understand better what's going on.
I love that. I love that. Well, Rakesh, and tell us, well, switch modes here, but tell us about gestational ages and therapeutic hypothermia. Quite the topic.
Oh, well, I think everybody knows the recent paper that came out from the NRN trial.
Yeah.
Which looked at preterm cooling in 33 to 35 weeks with moderate to severe encephalopathy. And, it took a while for the randomized control trial. They did what is called a Bayesian analysis. And based on that, they actually predicted that the probability of harm from cooling was actually higher than the probability of benefit. And as such, basically said, you should not be cooling babies between 33 to 35 weeks gestation.
Right. Practice changing.
Yeah, it was a real shakeup.
It did lead to a lot of consternation. I mean, there was some knee-jerk responses where you stop cooling everybody, and some people were like, oh, this is probably not the right thing to do immediately. We need more data. So it's taking a step back. If you look at the cooling trials, most cooling trials included babies over 36 weeks and above. There were few that included 35 weekers. So I think the prominent one was the ICE trial.
Right.
But overall, the number of babies who were at 35 weeks were actually relatively fewer. And the AAP and the guidelines that came out essentially said cooling at or over 35 weeks is okay. And then they reaffirmed that statement in 2021. And so for most places, will either cool at 35 or 36 weeks. And so CHNC has been collecting data since 2010, and we have now over 10,000 patients with HIE in the database.
Wow.
So, I mean, I have to thank the Explore team because they put this on a higher priority to pull out data for the preterm cohort, because we tried to see how many babies we have for preterm infants, 33 to 35 weeks in the cohort. And we actually have more than 1,000 patients,
No, it's a giant
uh,
cohort.
which is almost 10 times what they had. Well, I shouldn't say 10, almost 9 times more than they had in the trial. And again, this is a retrospective cohort, so there are always some limitations with that. So we are looking at babies who retrospectively, so obviously a little bit different than a randomized controlled trial. But we wanted to answer the question whether mortality is different between normothermia and hypothermia infants, which was actually one of the secondary outcomes in the randomized control trial. It was not a primary outcome. So just to be clear, and again, the analysis that we are doing is different. It's what you would call a frequentist analysis versus a Bayesian analysis. But what we do see is that for babies between 33 and 35 weeks, the mortality is actually lower in the hypothermia arm rather than the normothermia arm, which is kind of opposite of what they were seeing.
Yeah.
Um,
In your unadjusted analyses.
in the unadjusted analysis. The adjusted analysis, even though it is lower, the odds ratio are lower, but it does not reach statistical significance. I think it's about 0.06. So it's approaching significance. We did try to break it down by each gestational age, 33, 34, 35, because the NRN trial grouped them all together, and because the numbers are small. And what is interesting to see is that even at each gestational age, the mortality in the hypothermia arm is actually lower than the normothermia arm. So,
And if I can, I'll tell some people what these numbers are. So in your total cohort, of 1,048 infants, 33 to 35. Well, let's see, 162. Yep, right. For the 33 to 35 weekers, 162 infants. Mortality was 18% in the normothermic group, 13.6% in the cooling group. For that subcohort of 33 weekers, mortality was 20% in the normothermia group, 16.7% in the therapeutic hypothermia group. For the 34 weekers, 20.6% mortality in normothermia, 16% in therapeutic hypothermia, and in the 35 weekers, 14% for the normothermia group and 12.8% for the therapeutic hypothermia group. I didn't mean to interrupt, but I wanted people to be able to hear that.
so I think the overall trend is positive for the hypothermia group compared to the normothermia group, which is, like I said, kind of the opposite of what was seen in the trial. So that needs more parsing out. We did look at infants with moderate or severe HI as a separate subgroup analysis. And again, that trend persists, that have lower mortality with the cooling arm than the normothermia arm, suggesting that this benefit is going to persist. There are some limitations to the database because we do have HI coded differently at different times. So we have a diagnosis of CNS depression, which used to be one of the ways of capturing kids who have sort of perinatal depression, particularly the preterm infants. So
Is that the difference between, you have here CHND 1.0, CHND 2.0? So is that the difference in the data sets there?
that is actually a database quirk. So the nitty gritty of the database, CHND 1.0 was a previous vendor who hosts the database. 2.0 is a different current vendor who hosts the database. The diagnoses themselves have not really changed. I mean, we used to use a diagnosis of CNS depression for the preterm infants. So that is just to show us in which database, what the numbers are. And because we have a diagnosis of CNS depression, those babies would not have a severity of encephalopathy. So if you look at that database limitations, what you'll see is that almost out of the 340-50 kids, we had a diagnosis of unknown severity of encephalopathy.
Right.
Almost all of them have a diagnosis of CNS depression,
Right.
not HIE. So we included those babies because that's the real world. Those are babies who are in the database who have been either cooled or not cooled.
Right. Some of them received the therapy.
And some of them have received the therapy. So we want to know if this therapy is going to be effective or not. But we did do a sub-analysis after excluding those babies just to make sure it's not causing a bias. And interestingly, the mortality benefit persists for babies who are having a diagnosis of moderate or severe HIE or encephalopathy.
Very interesting.
Yeah.
So how do you think this adds to the discussion? It's been everybody's sitting down in their conference rooms to decide what to do as a team, or in Florida as a statewide, collaborative. Um, should we be revisiting this information?
Well, I think the interesting question that came out after the NRN trial came out is most people are very comfortable cooling at 36 weeks. And the question was, is 35 weeks any different than 36 weeks? So when we have a second part of the data that we're presenting, we're looking at each gestational age and looking at the mortality.
Right.
And there, if you look at the numbers, they are very similar for 35 and 36 weeks. I think 35 weeks are maybe 1 or 2% higher than 36 weeks. So overall, the trend is sort of benefit starting around 34 weeks and continues to improve. So a little bit of an upswing at 42 weeks, but those numbers again are smaller. We are looking at doing more analysis for that to identify at what gestational age you actually get the best benefit. And at what point would you say that this is not really effective? So hopefully more to come for that.
Yeah. And I appreciated that you were, even in your analyses, you're looking not just at mortality, but then also at the outcomes, like by MRI. And
Yeah, so we did look at some secondary outcomes. So one of the outcomes we looked at was, did the survivors go home with a feeding tube? Because unfortunately, the CHND database does not capture developmental follow-up. So we have done that independently outside the database for our predictive models. But because we don't have that, we kind of look at some surrogate markers to see what kind of morbidities would the survivors have. And what we see is that there is actually no difference between normothermia and hypothermia in terms of babies going home with a feeding tube. And that does not matter at each gestational age. Even though I think the numbers were a little higher at 33 weeks, but that may just be a function of being more mature. We also looked at that for moderate and severe HIE, and almost all the kids who go home with feeding tubes are more skewed towards being severe injury. So not because they're getting cooled or not cooled, but because they have more severe injury. And like you said, we looked at MRI data, which was actually kind of interesting, but again, a little bit of data limitation there because of the CHND 1.0 and 2.0, we had some limitations to data pool because we could not get the linkage to 1.0 completely. So we have data, what we're presenting for the MRIs only for survivors who had the available MRI.
Sure.
So it's a little bit of a biased data, but what it does show is that all the babies who survived actually were more likely to have normal MRIs. Well, I shouldn't say, I will take that back. I should rephrase that. The proportion of babies who survived with normal MRIs were higher in the hypothermia arm than the normothermia arm.
Right.
So suggesting that you are not surviving at the benefit or you're not surviving
with worse MRI.
with worse outcomes.
With worse.
Right.
So,
And for that, it was 40%. 40% in the therapeutic hypothermia group, 19% in the normothermia group. An odds ratio of 95%, statistically significant. And then you
An odds ratio of 4.1.
an odds ratio. Sorry, a 4.
So you were four times more likely to have a normal MRI in the 33 to 35 week babies if you underwent cooling.
Yes.
And that was pretty similar across the gestational ages here. Normal MRI by gestational age. I guess not statistically significant in the 33rd week or the 35th week. But in
maybe
these,
in numbers.
but in these 34 weekers, an odds ratio of 3.35, 26.7% in the therapeutic hypothermia group, 14% in the normothermia group.
Yeah, I think the odds ratio is for the moderate to severe HIE.
Normal MRI by
Not
gestational
right,
age.
yeah.
Either way, I think one of the the issues that arises here is we have this prospective randomized trial data in a small cohort,
Yes.
given the limitations of prospective RCTs, right? And how hard it is to recruit for an outcome.
Yeah.
And then we have this extremely, significantly larger retrospective cohort study with all of the biases that we are all well aware of that
Yeah.
um, that come along with retrospective data. And I'm a retrospective researcher, so I'm not criticizing it, but we really do have to find a way to balance this because this is even if the benefit wasn't there, it's still a different message than the increased mortality harm
Yeah.
that we were seeing in the prospective data.
Yeah.
So definitely a lot to think about as we move
Especially
forward.
when we were making decisions about individual gestational age weeks where
Yeah.
those numbers were really small. Yeah.
There is some nuance to this, which we're still kind of looking into. If you look at the NRN trial, the numbers are small, but the mortality is actually higher at 34 weeks
Right.
compared to 33 or 35.
Right.
And that kind of seems to drive the higher risk of mortality there. So if you look even at our data, it's a kind of interesting. The mortality at 34 weeks is actually higher than 33 weeks or 35 weeks.
Yeah, I saw that.
But survival with normal MRI is actually higher because so I guess if you don't survive, your chances of having a normal MRI are a little bit higher.
Yeah.
So there are some competing outcomes we're looking at and some nuances to this. So we're still trying to tease those things out. But it is an interesting signal that you see in both the retrospective data and the prospective trial. So whether your cutoff is going to be 34 weeks or 35 weeks, I think that's still kind of up for debate there.
That's really where you're going to make me lose sleep here is you're thinking about the 35 weeker, 35 and 6 weeker, now.
So it's a question of baby is 34 and 6 at midnight, it turns into 35 weeks. So suddenly you turn into Cinderella and you get cool
That's right.
versus not cool. So I don't think we have the answers yet, but I think this is some very provocative and interesting data.
For sure. For both of you, thank you so much for sharing this very important work. Things that we are going to have to think about right away at the bedside for both of these projects. We appreciate you joining us. Thanks so much.
Thank you for having us.
Thank you for having us.